Hello, class. Today we're going to be talking about pediatric swallowing and feeding assessment. This is the first of a two-lecture series on the topic of assessment. Although on the Moodle website, it indicates that the ASHA template that I have placed there for you is optional in terms of study. I do rely on those forms while I am lecturing on the topic of assessment. So it might be nice if you printed the forms or brought them up on the desktop of your computer and use them to as a template to take notes or to follow along as I'm discussing the general plan for assessment. So if you haven't done so already, you might want to go ahead and open up those docs, and then we'll go ahead and get started. So these forms are to be found on the ASHA website in the Pediatric Dysphagia Practice Portal. I've been pushing you guys to take a look at the practice portal, and the pediatric dysphagia was one of the early sections of the practice portal to be completed. It has all kinds of useful information, assessment forms or templates certainly, but it also has sort of state-of-the-art, evidence-based practice guidelines, nice information summarizing all aspects of this topic. So again, I would urge you to go ahead and take a look at this section of the ASHA website. There are two forms on the website. We're going to be talking in this lecture about the one for our youngest clients, and that would be for infants. The ASHA label at the top says 0 to 6 months, just so that you know that you're on the right page. I have some general topics to discuss in terms of pediatric assessment of dysphagia and feeding. There are four primary issues that I try to keep in mind, especially with infants, when I am looking at the baby to make some kind of assessment of their ability to tolerate oral intake of nutrition and liquid. The first of those factors has to do with the very intimate relationship between swallowing or PO intake and respiration. Now, this is true of everyone, regardless of your age, but it is particularly true of pediatric cases and the most true of neonates or newborns or 0 to 6 month old infants. That's because of a couple of factors. One, we've talked about already, the structural differences between adult and pediatric cases. It's also the case that infants still have emerging coordination development that needs to take place that helps them to balance the acts required for breathing and the acts required for swallowing. Swallowing, of course, requires airway protection. The second topic has to do with the overall tonicity of the infant's muscular system. Now, tonicity here is used in the sense of how much inherent tone is there in muscles of the body, even at rest. So in adults, we can palpate our muscles and note that there is some sort of firmness even when we're not consciously contracting the muscle belly. And the same we expect to find in infants, that even at rest, there should be some inherent tone. Now, if you look at the overall tone of an infant or a child while they're deeply asleep, there's going to be very little inherent tone in those muscles. But in an infant who is awake and alert, we would expect in the healthy baby to find some inherent firmness in the muscles, and that's going to be necessary for intentional acts as well as for acts that the infant needs to do in order to survive. The third topic, or the third factor that I try to keep in mind when I'm doing pediatric swallowing assessment, has to do with the status of the baby's so-called primitive reflexes or neurological reflexes. The presence or absence of these in infants and children has to do with the neurological integrity of the baby. And we would expect to find that in a newborn there would be certain primitive reflexes, as described in your textbook, that help the baby, again, to survive. So things like the rooting reflex that would encourage the baby to respond to any tactile stimulus that might have something to do with impending feeding. The fourth factor that I keep in mind has to do with the maturity of the gastrointestinal system. So while we expect and hope to find maturity in terms of respiratory control, we also are hoping that the gastrointestinal system has developed enough that the baby can tolerate and benefit from PO. I'm going to take this opportunity to remind you of the breathing feeding pattern that we expect to find in a healthy infant. That would be the suck, swallow, breathe pattern, so that that's the coordinated pattern that we ultimately are hoping that our infants will demonstrate. Suck to intake the liquid, swallow with protection of the airway, and finally breathe after the swallowing has taken place. Now, it's critical in infants who are what are called medically fragile to have them maintain oxygen sats at a particular level. This is also true with adults, as we know, but it's quite important in an immature system that infants be able to tolerate this even single moment of apnea in order to successfully benefit from PO intake. A suck, swallow, breathe pattern in a healthy infant is also related to cardiac and pulmonary health. So we look with a close eye at infants who have cardiac defects or pulmonary issues to make sure that they're going to be able to tolerate the apnea that's inherent in the suck, swallow, breathe process. A few special words, I guess, about gastrointestinal maturity, because we've talked about reflexes, we've talked about respiration and sucking. We haven't talked much about gastrointestinal maturity. We expect even very young infants, premature infants, to demonstrate some of the gastrointestinal developmental milestones that allow an infant to suck and swallow and digest correctly and successfully. So by week 29, we expect that an infant would demonstrate the ability to have peristalsis. So once food gets into the intestines, that the unconscious and not overtly consciously controlled contractions that propel food through our intestines, that process would already be there. Likewise, we expect by week 33 some coordination of sucking and swallowing. We had talked about premature infants earlier, and preemies younger than week 29, we would expect are not going to have the necessary patterns of sucking and swallowing, that are not going to have the peristalsis that is required to move food throughout the intestines. The other issue related to gastrointestinal maturity that's quite important is that even at a normal birth, so at 38 to 42 weeks, the digestive enzymes that we need to help process food and extract the nutrients that our bodies need do not develop until a number of months after birth. Now, breast milk has, as one of its many benefits, some of the digestive enzymes that an infant will need. But it is the case that infants are not really capable of benefiting from the nutrients in solids until around 6 months of age. So for cultures and families that are very interested in getting their infants started on solid food, it can be helpful to let them know that this might be, a milestone that is important to specific families, but that an infant will still need formula or breast milk to get the nutrition that they need. All right, moving on to the actual assessment form, I wanted to say a few words about our very, very youngest neonatal patients, especially the patients that we find in NICU, or the Neonatal Intensive Care Unit. Our infant patients, our very young patients, almost always come from NICU. If infants have genetic syndromes, if they have very early difficulties coordinating respiration and swallowing, if they have had very early trauma or are ill at a very young age, those babies are going to be in NICU, and that's where those newborn referrals are going to come from. So for those of us who haven't been in a NICU, I thought I'd show you a picture. This baby actually looks pretty healthy in terms of body appearance, although you can get a feel for the amount of tubing and medical equipment that's going to be around a very, very sick neonate. In NICU, you're going to find premature infants, as I mentioned, the syndromic cases who might have structural problems, and then those infants that I just discussed, cardiac, pulmonary, renal, neuro cases, some other kind of impairment that's going to affect their ability to swallow and feed. Here's a shot of what the entire nursery NICU intensive care unit might look like. You can see that there are isolettes in which the baby is kept. To even go into NICU, there are special precautions and preparations that all professionals and typically family members must take in order to keep the NICU unit as healthy as possible. Although the nurse in the foreground does not have a face mask and isn't gowned, you can see that the professionals towards the rear of the NICU are, and they're probably working with an infant where special precautions must be taken in order to keep the environment germ-free for those infants who are medically fragile. There's in addition to the special scrubbing up that you must do, and that includes it's special teensy-weensy nail brush that really cleans in a very thorough way. I wanted to mention that you need to find out when you're entering NICU for the first time what are the practices that the hospital has around working with neonates in that unit. Typically, they'll want to explain to you about working with babies who are in isolettes, so there's no, tapping on the isolettes to get the baby's attention. There are certainly lots and lots of bright lights in NICU, but as you can see in this photograph, most isolettes will have the babies shielded from those bright lights, which is a really abnormal sort of set of circumstances. You can also expect to find families in somewhat of a state of crisis. They're upset because the baby is sick or hurt or has some kind of medical syndrome, and none of that is what people think about when they think about having a new baby in the family. The baby may have come earlier than expected if the baby is a preemie. So all of those things add up to families who are typically very upset and distraught, and you need to be prepared for that before you go in. I will also say that the NICU and specific hospitals that I've been in have been the site of some disharmony between professionals, that's how I'll put it, that nurses in NICU take their work very, very, very seriously. And sometimes if there hasn't been enough professional education, they will not be that supportive of other professionals entering their terrain. So you have to enter with a sort of a spirit of cooperative work and finding out what the spoken and unspoken rules are for working in that environment. A few other special considerations for working with infants. Your textbook mentions the phrase A's and B's during feeding. And what this means is that apnea and bradycardia, so moments when the baby either stops breathing or breathes quite slowly, those A's and B's are a matter of great concern in fragile cases. So when you hear that, you know that it refers to changes in respiration. Babies who are very, very sick in NICU also are going to fatigue easily. They're going to have very poor endurance, and this might mean that it will be difficult to get them to take enough ounces of nutrition in order for them to thrive. I've already mentioned the poor coordination of the suck, swallow, breathe sequence and how that is often quite characteristic of neonates in NICU. And you might also find in developmentally immature babies and developmentally immature pediatric cases with neurological damage, some hypersensitivity or what is called oral defensiveness, trying not to allow oral stimuli or a turning of the head so that there is no intrusion into the oral cavity. And this can make, for newborns, feeding very challenging because even the presence of a nipple or a pacifier can, in the beginning, elicit signs of oral defensiveness. Finally, I wanted to say that despite the fact that there is one type of substance in neonates, that would be liquids, right? Because they're not going to be eating solids yet. There are many subtypes of liquid and bottles and delivery systems. So infants in NICU will sometimes be breastfeeding, and which means that the mother will be, in all likelihood, right there most of the time. Infants might also be bottle fed as a supplement to breastfeeding and or in an attempt to get the baby used to oral stimulation. And in infants who are not ready for oral intake, you will see gavage feeding. That is, the infant who has a tube which is inserted up and over the velum and into the pharynx, helping them to get nutrition even if they have poor suckle or suckling reflexes and abilities. So it's sometimes called the infant NG tube, gavage feeding. It is a tube. It looks a lot like an NG tube that you might see in adults. Here's a picture of a typical gavage tube. Sometimes the gavage tube goes just into the pharynx. Sometimes it is inserted all the way into the esophagus and down into the stomach for the very sickest babies. And this allows them, like I said, to get nutrition even when their own ability to take in PO is weak or absent. Even if the baby is on a bottle of some sort, there are sort of infinite variations of bottles and nipples. Even healthy babies soon develop preferences for a specific kind of bottle if they are getting nutrition from a bottle. So you can see in this picture here, the Mead Johnson bottle that has the ounces clearly delineated. This is a bottle that fits nicely into the hand. It, can contain up to 4 to 6 ounces, and typically nursing staff is happy if newborns are taking in about 4 ounces of liquid at a feeding. Sometimes you will see that there are special kinds of valves or special cuts in the nipple or special nipple shapes. And for a baby who is not taking bottle administered liquid very well, there may be some trial and error in terms of trying to find a nipple that capitalizes on the baby's abilities without flooding them, without too much liquid at the beginning, and also not making them work too hard. So the size of the aperture, the opening in the nipple, can be adjusted. This is true for very healthy, normal babies. If you buy nipples and bottles for preemies and neonates, you'll see that the openings are typically pretty tiny so as to not flood them with too much at one time. As infants get older and develop, the openings on the nipples are either bigger as you buy them, or you can cut an additional hole in the nipple to make the passage of the liquid easier. There are special bottles that are often used for infants who have clefts or structural defects, and these would be very similar to the Haberman feeders that are here. They're small bottles that allow you to insert the nipple towards the posterior aspect of the baby's oral cavity, and thus try to avoid getting the liquid into the nasal passages as much as possible. So let's look specifically at this template. I'm not going to go over the entire form with you, but I wanted to highlight a few things in the history. You can see there's fairly detailed information that you can note in terms of neurologic and cardiac history. So everything from the presence or absence of specific events that occurred in the baby's early history, to noting specific diagnoses, for example, the presence of hypotonia or microcephaly. You'll want to note also in terms of the cardiac history, have there been specific diagnoses of cardiac problems? And does the baby have a history of being somewhat cyanotic or blue, or meaning that there's reduced oxygenation in the blood? You're also going to want to get feeding and swallowing history. Are there positions or characteristics of the food or liquid that are preferred by the baby? How long does it take a baby to take in sufficient PO? And is the baby breastfeeding, bottle feeding, some kind of combination of those? If the baby is breastfeeding, then again, we're going to look at some of the characteristics of an optimal environment for the baby. So, how long does the baby spend when breastfeeding? And does the baby, again, have a specific position that they need? Does the baby, get fed on demand, or is there some kind of a schedule? And what is the baby like when feeding? Vigorous, fussy, lethargic? It doesn't have this option here, but is the baby sleepy? So it's very common in babies who have to work super hard that they would do their best for a couple of minutes and then be done because the effort has been so great. In the actual assessment, you're going to note all of the same kinds of things that you typically might. If we look here at F1, you'll see that you do an oral peripheral exam, and you're used to that, although not typically in infants who are newborns. But you're going to be looking for weakness and reflexes and their ability to manage secretions, and you're going to do your very best to observe any structural defects in the infant. You're also going to be looking at certain behavioral and respiratory factors that have to do with how alert and awake the baby is, how oxygenated they are, and if the baby seems to be in pain. So I will post for you the neonatal infant pain scale, NIPS is what it's called, and you probably will not be the person to assess the baby, but you should know that there is a scale now that is used. There are a number of them. I have to say NIPS is the one that I've encountered most often, and you're looking for a score out of 7 possible points to tell you how much pain the baby is likely to be in. Once you have observed the baby feeding, you might be the person doing the feeding yourself. You might be observing if the baby is breastfeeding, or if the nurses prefer or the parents prefer to do the feeding themselves. On the form, you'll see that there are check boxes for these items, just like there were for some of the earlier extracts from this form. And you're going to make as many observations as you can. Is the baby able to suck, but suction is very weak? Does jaw movement seem excessive and sort of inefficient? Is the baby having difficulty finding a nipple and latching on? Is there difficulty with sort of the rhythmicity, meaning the regular pattern of that suck, swallow, breathe that we expect to have? And are there other behavioral indications that feeding and PO intake is not that successful? You're going to notice, again, under 2 other categories, certain patterns that have to do with respiratory coordination, as well as are there any symptoms that suggest that there is airway compromise in the baby who is feeding. So that's going to be everything from color changes, becoming less pink and more blue while feeding. Are there abnormal respiratory patterns? Do you hear a wet voice when the baby cries or breathes after intake? And in general, you're going to be noting as much as possible, do you find any symptoms that would suggest that feeding patterns are abnormal and that there could be airway compromise during the feeding process? Finally, just like in any assessment, you're going to be asked for your overall impression. You will be asked if you think there is a likelihood that there is dysphagia, what type, and how severe. So oral or within functional limits, or pharyngeal or esophageal, And then you're going to be asked, do you think it's a mild, moderate, severe, or profound problem at each of those stages? If you have any questions about that, you may decide that you need referrals and additional assessment, and we'll look at that on the next page. You're asked to make a judgment also about how safe the baby is for PO and how much risk you think as a clinician there is for aspiration. I included at the bottom here the diagnosis code. You will be asked to provide from a list that's given at your facility the ICD-9 or now ICD-10 codes that correspond to the problem that you have seen. So if you are diagnosing, for example, that there is oral dysphagia, you're going to be asked to put it on the line and circle the diagnostic category that captures what is happening with this infant while feeding. You will not be the only person making this kind of diagnosis or judgment, but this is required in a facility in order to be able to bill for the procedure that you have just completed, to be able to amass data on the kinds of cases that they see, and in general to establish the nature of the populations that are in the facility. You're going to recommend how should this baby get their PO. So this part is very similar to the recommendations form that we might have for an adult. You're going to note, should the baby have PO or not? Should we have more data? Do we need other kinds of assessment before we can make a decision? Does the baby need some kind of outpatient feeding treatment or therapy program? And that's going to depend on what's wrong with the baby. So a baby who is immediately gagging, vomiting, and apneic because of, let's say, a tracheoesophageal cleft is not a good candidate for outpatient feeding therapy because they have structural issues. If you look down at the bottom here, you're also asked if you think there should be a referral to a specific medical specialty. Again, you won't be the only person assessing this baby. Typically, infants are seen and diagnosed and treated as part of a team. But you will be asked for your clinical opinion based on what you observe in the assessment section and what you read and discover as a result of looking at the baby's history. You will also be asked to overtly state what is your plan of care. And for those of you who have been doing therapy already, I think that will be all of you, you'll see again, what is your planned intervention? What are your long-term goals? What are your short-term goals? And in medical settings, you're required to document that you have a plan, that you reviewed the plan with the family, that the family seemed to understand, and the recommendations, the results of your assessment and the recommendations that you might have. Very important. Again, this isn't so different from what we might do in any setting, but it's required documentation in a medical setting. In the next lecture on assessment, then we'll look at assessment of older infants and toddlers and also talk about a little bit about our older pediatric cases who are not inpatients, but who have behavioral issues that prevent them from eating and tolerating fluids and or solids in a normal way.